with a client who has their 30-year-old brother and son in ICU, ventilated with Down syndrome, as well as supposedly hypoxic brain injury after cardiac arrest. My name is Patrick Hutzel from IntensiveCareHotline.com, and this is another quick tip for families in intensive care. So currently we're working with a client and member who has their 32-year-old brother and son in ICU with Down syndrome. He's a non-verbal patient. He's got a history of hypothyroidism, gout. He's obese, and he had a cardiac arrest at home. He was at home with his family. He was found in acute respiratory distress. Oxygen saturation was about 50% on room air when the ambulance arrived. The ambulance noted copious secretions and agitation. They gave 5 milligrams of haloperidol for behavior, placed on 15 liters of non-rebreather mask whilst they were on their way to the emergency department. Upon arrival to the emergency department, he became tachypnic, meaning he was breathing really fast. Oxygen sats were between 70 to 80% with worsening respiratory efforts. Then there was a plan for BiPAP and ketamine, but patient ended up in bradycardia, which is a really low heart rate, and had a cardiac arrest. A PEA, pulseless electrical activity arrest, occurred in the afternoon. CPR was initiated. Return of spontaneous circulation achieved within 12 minutes of low flow CPR. The client got intubated, started on vasopressors for low blood pressure and sedation. Initially in the emergency room, they found he has a pneumonia, Pasteurella multocida, isolated from the sputum culture, white cell count 20.9, which indicates he's got an infection. Lactic acid was normal, early septic shock. Transferred to ICU within a few hours, where he remained intubated, sedated, and paralyzed, treated for multifocal pneumonia and ARDS. ARDS stands for acute respiratory distress syndrome. It's also commonly known as lung failure. He then had an EEG, which showed severe generalized slowing with burst suppression, increasing suppression over time, no seizures, suggesting profound cerebral dysfunction. EEG basically checks the electrical activity of the brain. Next day, chest X-ray was done and it showed a bilateral infiltrate or infiltrates consistent with ARDS/lung failure. An attempt was made to evaluate for neurological infection, began due to persistent fever and suppressed EEG. Patient came off paralytics and sedation and still showed no purposeful movement, no gag reflex, minimal brainstem reflexes. MRI scan was done on the next day, which showed extensive cortical and subcortical damage, diffusion abnormalities, and cerebellar involvement. Diagnosis: severe hypoxic ischemic brain injury. On the same day, the neurology team at ICU team had a meeting with the family, explained, quote unquote, poor prognosis, and supposedly not a candidate for neurorehabilitation due to lack of responsiveness. Family opts to continue full medical therapy and time-limited trials. 2 days later, patient remains intubated, ventilator switched to pressure control mode on 60% of FiO2 or oxygen delivery from the ventilator. He's on a PEEP of 10 and a pressure control of 20, which is quite high levels of ventilation support. The arterial blood gases had improved to a PO2 of 210 with a pH of 7.44. White cell has been trending down, but is still elevated at 25.4. And is likely reactive to the antibiotic therapy. Still, what ICU describes as no meaningful neurological response. Strong corneal reflex, left weak, right. No gag reflex, no longer sedated, and neurologically minimally reactive. Now, the current diagnosis is a severe anoxic brain injury post-PEA arrest after 12 minutes low flow CPR, acute hypoxemic respiratory failure secondary to ARDS from multifocal pneumonia, septic shock, which is now resolved, ventilator dependence with now FiO2 of 60%, oxygen delivered from the ventilator, PEEP of 20 in pressure control mode. Suspected also ventilator-associated pneumonia, no positive sputum culture, hypernatremia, now improving with fluid resuscitation, steroid-induced hyperglycemia, now on insulin drip, and he's got diarrhea, non-C diff, and that's being treated with gastrostop. Now, pending and key points: awaiting lumbar puncture to evaluate for a CNS infection. Continuing empiric coverage: ceftriaxone, ampicillin, vancomycin, acyclovir to cover the infections. MRI and EEG are both consistent with profound hypoxic injury, not reversible. That's what ICU says. Ventilator changes made due to worsening pulmonary edema. Still no signs of what the ICU describes as meaningful neurological recovery, though corneal and cough reflexes persist. So, ventilator snapshot again, it's in a controlled mandatory ventilation mode with a rate of 18, tidal volume of 300, PEEP of 14, FiO2 of 40% now, CO2 is sitting around 40 millimeter of mercury, and peak pressures are around 27 with adequate ABGs, arterial blood gases. Vital signs are stable of inotropes and vasopressors. So, by showing some body reflexes lately, some eye movement like blinking tears, the team had a meeting with the family again, and they're kind of saying this is it for him. This is obviously now the family paraphrasing and summarizing the meeting they had with the family, saying this is it for him, referring to their brother and son, and they're hinting on discontinued life support. I hope you can help me guide through this. I told him absolutely not right now. We're going to give him more time. And absolutely, that is what you should be doing. It's only been a few days. And you need to give with hypoxic brain injury, you need to give patients with hypoxic brain injury in ICU, you need to give them time. The first step here is to make sure your brother and son can leave ICU alive. And once that's been achieved, then you can look at recovery. And also, if things are not progressing as you want them to progress, there is plenty of time to talk about end of life. This is what I never understand, that ICUs are so rushed to end people's life. And that is inappropriate. It is up to families what they want for their loved ones, or it is up to patients, of course, if they have an advanced care directive. In the absence of an advanced care directive, it is entirely up to families to share their wishes, right? And what you need to do here is really play on time. Let your brother get a tracheostomy if he's not waking up and if he's not progressing from a ventilation point of view, because over time, a tracheostomy will give him time to wake up. Now, there's no guarantee he will wake up, but there is a guarantee that if they stop life support, that he will die, right? That is the guarantee. Now, by continuing life support, you give him a chance of getting him back to baseline. Maybe he will not get back to baseline, but maybe he can live a quality of life that is acceptable to him, that is acceptable to you and your family, right? Life is sacred, right? And time will tell everything that you want to know, whether your brother will wake up or not. Time will tell you everything you need to know. And the ICU team doesn't want to give you the time because they're pressured for beds, they're pressured for resources, they're pressured for staff. I've worked in intensive care nursing in 3 different countries for over 25 years. So I do understand intensive care units, how they operate inside out. And they also want to stay in control and want to make decisions who lives and who dies. And that is highly inappropriate as far as I'm concerned. Also, keep in mind, he's only been off sedation and opiates and paralytics for a few days. It is very early days to assess whether he can or he can't wake up. Keep in mind, there's plenty of patients in ICU that don't have a brain injury, that come off sedation, opiates, and paralytics and don't wake up straight away, right? Also, another good sign here is he doesn't have any seizures, doesn't have any seizure activity. That is actually a good sign. A lot of patients that I looked after in ICU after cardiac arrest, and a lot of clients that we've dealt with over the years at intensivecarehotline.com. After hypoxic brain injury, most patients have seizures, have seizure activity, and that is not the case here. So I would give this some time, as much time as you would like. It is not up to ICU teams to decide when and how your brother should end their life. It is up to you to keep advocating for him, which is what we are here to help you with. And they already know they can't just make that decision, and they can't just tell you, oh, tomorrow at 3:00 we are ending your brother's life. That is highly inappropriate. It's illegal, and in most jurisdictions. And you should keep advocating for that. And there's plenty of time to talk about end of life. Plenty of time to talk about end of life. The question that you always need to ask is, where is the urgency to kill someone in intensive care, right? Where's the urgency? Why is there no urgency to get your brother a tracheostomy and see whether he can recover, start to get him mobilized once he's hemodynamically stable, once he's, shows no sign of infection any longer, then it's time to start him getting mobilized. That is a very different conversation to have, as opposed to ending your brother's life. Very different conversation to have. And also, after about 2 weeks of mechanical ventilation in ICU with a breathing tube, it's time to do a tracheostomy, assuming your brother can't be weaned off the ventilator, right? If he's not waking up. Once again, that's what a tracheostomy does. It's buying people time. It's giving them a chance to recover, assuming all the right things are being done, i.e. starting to mobilize patients, making sure they get physical therapy, making sure they're getting mobilized and they have a fair chance at recovery. And it's also interesting that as part of the families and our clients' discussion with the intensive care team, they want to have a follow-up meeting with the neurologist, and they keep asking the family why, right? As if the family is an inconvenience when they're asking for meetings. Again, that's highly inappropriate. And they're also saying now they don't want to do a spinal tap or a lumbar puncture because due to, perceived complications when they turn him over. Look, the reality is this: whenever there's a procedure happening in ICU, whether it's a lumbar puncture, whether it's any type of procedure, surgery, minor surgery, whatever it is, there's always a risk of complications, always. Now, the reality is that if they don't do anything, the highest risk here is this gentleman will die, right? So that's unfortunately how some, not all ICUs are operating. There's a lot of good things happening in ICU, but obviously we are dealing, our clients here, they come to us because they are often at their wits' end, and that's what we're here to help them for, and how to advocate, and we advocate on their behalf. Your job is to avoid the worst case scenario and give your brother the best chance at life. And if you're asking for a meeting, that is perfectly reasonable, right? Always bring it back to what's reasonable. Always trust your gut, and keep advocating. And if none of it works, my suggestion is that you go to hospital executive, that you take the complaint outside of ICU, and you will find that hospital executives often will help because they have to, right? So I hope that explains the situation to you. I have worked in critical care nursing for over 25 years in 3 different countries, where I worked as a nurse manager for over 5 years in intensive care. And I've been consulting and advocating for families in intensive care since 2013 here at intensivecarehotline.com. And I can very confidently say that we have saved many lives for our clients in intensive care. And you can verify that on our testimonial section at intensivecarehotline.com, or you can verify it on our intensivecarehotline.com podcast section, where we have done client interviews. And And there we explain, our clients tell you how we help them to save their loved ones' lives, because our advice is absolutely life-changing, right? The biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights. They don't know how to manage doctors and nurses in intensive care. And that is a big challenge to deal with, right? But that's what we are here to help you step by step, because we're getting results and outcomes for our clients. Now, we help our clients to improve their lives instantly so they make informed decisions, have peace of mind, control, power, and influence. And you can join, and making sure their loved ones get best care and treatment always. And you can join a growing number of members and clients that we have helped over the years to improve their lives instantly, making sure their loved ones get best care and treatment always. And that's why I do one-on-one consulting and advocacy over the phone, Zoom, WhatsApp, whichever medium works best for you. And I talk to you and your families directly. I handhold you through this once-in-a-lifetime situation that you can simply not afford to get wrong. I also talk to doctors and nurses directly with you or on your behalf, or I'll set you up with the right questions to ask. And when I talk to them directly, I ask all the questions that you haven't even considered asking, but must be asked when you have a loved one critically ill in intensive care, and you will see the dynamics change in your favor very quickly. I also represent you in family meetings with intensive care teams. We also do medical record reviews in real time so that you can get a second opinion in real time. We also do medical record reviews after intensive care if you have unanswered questions, if you need closure, or if you are suspecting medical negligence. We also have a membership for families of critically ill patients in intensive care, and you can become a member if you go to intensivecarehotline.com, if you click on the membership link, or if you go to intensivecaresupport.org directly. In the membership, you have access to me and my team 24 hours a day in the membership area and via email, and we answer all questions intensive care related. You also have exclusive access to 21 videos and 21 ebooks that I've personally written and recorded, and all of that will help you to improve your life instantly, make informed decisions, have peace of mind, control, power, and influence, making sure your loved one gets best care and treatment always. And all of that you get at intensivecarehotline.com. Call us on one of the numbers on the top of our website, or simply send us an email to support@intensivecarehotline.com with your questions. And if you like my videos, subscribe to my YouTube channel for regular updates for families in intensive care. Click the like button, click the notification bell, share the video with your friends and families, and comment below what you want to see next, what questions and insights you have from this video. I also do a weekly YouTube live where I answer your questions live on a show, and you will get notification for the YouTube live if you are a subscriber to my YouTube channel, or if you are a subscriber to my intensivecarehotline.com email newsletter at intensivecarehotline.com. Thank you so much for watching. This is Patrick Hutzel from intensivecarehotline.com, and I will talk to you in a few days. Take care for now.